Good evening, everyone. This is Beth Seidel. I am one of the technical assistance providers at ICAP for the We Choose Health Baby Friendly Hospital project. We are really glad that you joined us this evening for our webinar. For those of you who don't know, the Illinois chapter of the American Academy of Pediatrics, also known as ICAP, is an organization of approximately 2,300 pediatricians in Illinois. Our mission is to promote the right of all children to live happy, safe, and healthy lives, to ensure children receive quality medical care from pediatricians, and to assess and serve the needs of its membership. This baby-friendly hospital project falls under the umbrella of obesity prevention initiatives at ICAP, but it works closely with ICAP's Committee on Breastfeeding. The project is part of the Illinois Department of Public Health's We Choose Health initiative, which is made possible by funding from the Centers for Disease Control and Prevention. As part of the We Choose Health Baby Friendly Hospital project, ICAP provides technical assistance to We Choose Health grantee communities and the local hospitals they are working with to promote breastfeeding and become baby friendly. I provide technical assistance at the individual, hospital, and county levels to help grantees and their partners work toward baby friendly designation. So we are really excited to have Dr. Crystal Revai speaking on our webinar today. Dr. Revai is a care management medical director for Aetna and an assistant professor in the Department of Pediatrics at the University of Illinois in Chicago, where she leads their baby-friendly hospital initiative. Dr. Revai is co-chair of the Illinois chapter of the American Academy of Pediatrics Breastfeeding Committee and is the chapter breastfeeding coordinator. She is a board-certified pediatrician and a fellow of the Academy of Breastfeeding Medicine. I'm going to go ahead and give it over to Dr. Revai.
Thank you, Beth. Thank you. It's good to be here, and I'm happy to speak to you all today about the Baby Friendly Hospital Initiative, why and why now. So this is part of the We Choose Health Baby Friendly grant project that Beth was speaking about earlier. The project goal is to increase the number of baby-friendly hospitals in Illinois by 15 hospitals. And the participating hospitals will be designated baby-friendly by 2016. The hospitals collaborate with health departments and other community partners. And this was made possible by the We Choose Health initiative is made possible by funding for the Centers for Disease Control and Prevention. This is a map of all of the counties that are participating in the grant currently, and you also see on the left-hand side the specific hospitals within each county that are participating. The objectives, by the end of this presentation, participants will be able to name 3 diseases for which formula feeding increases risk, list 3 current initiatives that address maternity care practices, and state 2 practices that contribute to breastfeeding success. Our outline for today, we're going to discuss the evidence for breast milk, the cost of formula feeding, what are some of the current initiatives that are going on around breastfeeding, and what is the Baby Friendly Hospital Initiative. I'm trying to find my, there we go. The benefits of human milk, I'm sure most of you know, extend well beyond infancy, and it impacts the health across the lifespan of both the infant and the mother. Breastfeeding is a critical resource for health that exists in all communities, and it may very well be the most important choice a mother can make when her baby is born. We know that babies that are formula fed have increased rates of neck, respiratory infection, sepsis, in neonates ventilator use, and in all children, sudden infant death. In terms of chronic diseases, formula-fed infants have greater rates of obesity, developmental disabilities, both type 1 and type 2 diabetes, as well as asthma and allergies. From the mother's perspective, mothers whose formula feed have greater risk of multiple types of cancer, including breast, ovarian, and thyroid cancer. They have higher rates of osteoporosis, postpartum depression, and metabolic syndrome. In terms of exclusivity, does exclusivity matter? Is it important? It's clear, especially from the last AEP statement on human milk, that breastfeeding is more than just a lifestyle choice. It's an evidence-based individual and public health measure. The impact of exclusivity increases health outcomes for breast milk, benefits exponentially for infants and mothers, and breastfeeding duration increases with exclusivity, as you can well imagine. The cost of formula feeding, beyond the actual cost of just buying the milk, we know that suboptimal infant feeding practices in the United States have resulted in estimated $13 billion per year in excess costs, and this is 2010 estimates, so we can only imagine what it is now, 4 years later. In terms of WIC, it does cost about, at least in 2002, so we're dealing with even older data, that WIC, it costs about $578 million per year for WIC to subsidize the purchase of formula. What are the costs in terms of healthcare spending? $3.6 billion per year is spent to treat just 3 conditions that are preventable by breastfeeding for a minimum of 6 months, and those are diarrhea, respiratory infections, and ear infections. From a hospital standpoint, sicker babies result in higher costs. Many of you probably know that for neonates, sick neonates cost the hospital money. Healthy neonates or feeder growers is where hospitals have the opportunity to make a little money on neonates. So for every case of neck, each case of neck costs about, this is non-surgical neck, costs about $200,000, $90,000 of which becomes hospital debt. Hospitals also spend between $26,000 to $30,000 on lower respiratory tract infections, and poor breastfeeding practices in the newborn period can lead to more readmissions. So what are some of the current initiatives that are affecting breastfeeding practices and are related to breastfeeding? There are numerous governmental and non-governmental healthcare agencies that are evaluating hospital breastfeeding practices and promoting those that are evidence-based. Sorry, I'm having a little trouble advancing. There we go. The first is MPINC. That is a CDC survey on maternity care practices in infant nutrition and care. It's a national measurement tool, and it's distributed to hospitals around the country. It is a self-report. And on the last MPINC survey, which came out in 2011, Illinois ranked 36. And that asterisk is there to remind me that this is actually a decrease in rank from 31st in 2009. So we were 31st out of 50 states for our maternity care practices in 2009. From 2011, we dropped 5 points to 36th. And I can tell you that from the next slide, you'll be able to see, you know, what from the MPINC survey are the needs for quality improvement in Illinois hospitals. Decrease in inappropriate usage of supplementation with water, formula water, glucose water, the inclusion of model breastfeeding policy elements, the initiation of skin-to-skin care, protecting patients from formula marketing, and the appropriate use of breastfeeding supplements. And I can tell you that from a statistical standpoint, it's not that Illinois was doing worse. We didn't lose ground. It's that other states improved at a greater rate than we did between 2009 and 2011. Specifically, where's the room for improvement? 41% of the facilities in Illinois initiate skin-to-skin care for at least 30 minutes upon the delivery of a newborn. Only 19% of facilities in Illinois adhere to standard clinical practice guidelines against routine supplementation with formula, glucose water, or water. And only 29% of facilities in Illinois adhere to public health recommendations against distributing formula company discharge packs. And that is the formula company discharge practice. One of the primary things is considered protection against formula marketing. In 2013, we initiated the Illinois Hospital Infant Feeding Act, which requires all hospitals to have a written breastfeeding policy. Baby-friendly practices are to be followed as a model, and only 11% of the facilities in Illinois have comprehensive breastfeeding policies. I'll tell you that the Academy of Breastfeeding Medicine, or ABM, has a very, very good model policy that is based on the baby-friendly steps. And if you're looking for a policy, or if you're looking for a protocol, don't reinvent the wheel. You can go and find a nice policy that you can make some minor changes to meet your facility's need. And that asterisk is there to remind me to say that the ABM is a very good source for multiple different types of policies around breastfeeding, whether it be, the indications for supplementing a sick child, whether it be the evaluation of hypoglycemia, jaundice, etc. There are many, many policies translated into a number of different languages if you, by chance, need them on the ABM website. We have the Illinois Breastfeeding Blueprint. This is an analysis of statewide data on breastfeeding rates and disparities, and it's specific Illinois data on hospital maternity care practices. This data is specifically Illinois, from within Illinois. The top 4 reasons why Illinois women gave for not breastfeeding between 2004 and 2008. The highest you see across the ethnicities was that they didn't like breastfeeding. I'm not sure, nobody's really sure what that means, but they didn't like breastfeeding. And then the other reasons, the top 3 reasons were no other children to care for, had to go back to work, and got sick and could not breastfeed. So you can see at least 2 to 3 out of these are reasons that are amenable to education. How to deal with breastfeeding when you go back to work or school. What are the indications for when is a mother too sick to breastfeed, and when is it actually better for the mother to breastfeed through the sickness? Here are the top 4 reasons why women in Illinois gave for stopping breastfeeding. So this is all, women who initiated breastfeeding and why did they stop. Number 1 reason, and this isn't just in Illinois, this is, consistently across breastfeeding women, is that I thought I was not producing enough milk. Other reasons, breast milk alone did not satisfy babies, which is sort of the same as I wasn't producing enough milk. The baby had difficulty nursing, and I went back to work or school. So all 4 of these are amenable to maternal education and help. Moving on to the Surgeon General, there was a call to action to support breastfeeding. Just to give you some historical perspective, the last call to action from the Surgeon General was around tobacco cessation. So that's how critical a topic this is for the Surgeon General. This was back, the last one was back in the 70s where that Surgeon General, and I forget which one it was right now, felt that it was important to target tobacco cessation. And this Surgeon General was saying it's as important to support the increased breastfeeding rates and duration. It requests, one of the key points is that it requests greater support for breastfeeding in the United States. It identifies 20 action steps which are recommended to improve breastfeeding practices, rates, and maternal child outcomes. And this is a really nice document if you've got a chance to look through it. The Joint Commission, which is near and dear to many of our hearts, those of us who work in hospitals, has included breast milk feeding, exclusive breast milk feeding, as one of its 5 perinatal core measures. And hospitals with more than 1,100 births per year have to report exclusive breastfeeding rates. And there's a nice toolkit with the link that you can see to help you understand how you need to, how the Joint Commission is going to look at and evaluate these breastfeeding rates. There's the Illinois Hospital Report Card, which is a hospital quality rating for consumers. This is a searchable site within Illinois. Consumers can go in and look at a number of different factors in terms of quality factors in hospitals. Exclusive breastfeeding rates have been approved for inclusion, but there's also cesarean section rates. They can look for outcomes after, infection rates after a cesarean section, et cetera. So this is a really nice place where consumers go to look for quality, and exclusive breastfeeding has been included. We've got a breastfeeding toolkit in Illinois, which is a resource for hospitals. Again, a model breastfeeding policy, some information about practice changes, data collection, and scripting. Just about every health provider organization, I've named we've listed just a couple here, but you can go through to just about any healthcare provider organization that relates to the care of mothers and babies, and they have a policy statement encouraging and promoting breastfeeding, exclusive breastfeeding. Here in Illinois, we also have a physician statement on breastfeeding. It was developed in collaboration with the 3 primary groups of physicians who take care of mothers and babies. Our organization, ICAP, as well as the Illinois Academy of Family Physicians, the Illinois section of the American Congress of Obstetrics and Gynecology. And it provides a nice guidance and evidence-based standards for the care of the mother and baby throughout the continuum of the breastfeeding experience. So it really goes from the prenatal education and prenatal preparation for breastfeeding all the way through weaning and even around some advocacy issues. Other current initiatives in Illinois, the Illinois Perinatal Network have approved evidence-based hospital initiative, which was a statewide initiative in 2013. And the goal of that initiative was to make hospital environmental changes and maternity care practices to support initiation, continuation, and exclusivity of breast milk feeding. So the reason we're here is, to talk about the Baby Friendly Hospital Initiative. And this is a global program sponsored by the WHO and the United Nations, or UNICEF, the United Nations Children's Fund, to encourage and recognize hospitals and birth centers to offer an optimal level of care for infant feeding. Currently, in the United States, we have 175 hospitals or birthing centers that are considered baby-friendly. It's a small fraction of the number of baby-friendly centers worldwide. There are it's probably over 3,500 now. In Illinois, we have 4. St. John's Hospital in Springfield, Pekin Hospital in Pekin, Little Company of Mary in Evergreen Park, and St. Mary's Hospital in Decatur. The last 2 were just added in the last, it's been about 14 to 15 months now. So before 14 to 15 months ago, we had just 2. What are the 10 steps to successful breastfeeding? The first is to have a written breastfeeding policy that incorporates and addresses all the 10 steps. The second is that all the staff that take care of mothers and babies need to be trained. This includes nursing staff, technical staff, as well as physicians. And it's different. There are different requirements for hours based on the type of staff you are. Prenatally, step 3, prenatally inform pregnant women about breastfeeding, and then the encouragement is that this is done in a non-neutral fashion. So the question no longer is, have you thought about breastfeeding? What have you thought about feeding your baby? But now it's really, and we'll get to a little scripting in a little bit, it's really about saying, you should breastfeed your baby. Step 4 is to initiate breastfeeding within 1 hour of birth. Step 5, show mothers how to breastfeed and maintain lactation if separated from their infants. Step 6 is to offer no food or drink other than breast milk, and of course, that's unless medically indicated. Step 7, practice rooming in. Mothers and babies should be in the room together throughout their hospital stay, from delivery all the way to discharge. Step 8, encourage breastfeeding on demand. The teaching no longer is you should feed your baby every 2 to 3 hours, you know, like a clockwork. Really, it's encouraging and teaching mothers and fathers about feeding cues and reading their baby and getting them to better understand when the baby is hungry rather than looking at a clock. And that's important for babies no matter how they choose to feed them, for parents no matter how they choose to feed their babies. Offer no pacifiers or artificial nipples. And step 10 is to, sorry, that was step 9, and step 10 is to foster the establishment of breastfeeding support groups. And that doesn't mean that you have to have a breastfeeding support group in your hospital or at your clinic. It means that you have to encourage them, you have to have information about them, perhaps develop a relationship with the people who run the support group, but you don't have to have your own support group. What Baby Friendly is not, it's not forcing all mothers to breastfeed. It's really about giving mothers an informed choice. Studies have shown that mothers would prefer to have been informed and help make their own decision rather than just assume that they were going to formula feed. And many mothers have said anecdotally, "Oh, if I had only known what a good thing this was and how much better this was, I would have, you know, considered it. I would have breastfed." And it's not about eliminating formula altogether. We know that some mothers will not be able to breastfeed. We know that some mothers will choose not to breastfeed, and so and we know that some babies may need formula. So the hospitals will have formula. It is evidence-based maternity care practices, facilitating the best possible health outcomes. It's family-centered care. It's support for the mothers no matter how they choose to feed their baby. Skin to skin, rooming in. Skin to skin has been shown, we'll talk a little more about skin to skin in a minute, but skin to skin has been shown to increase parental confidence no matter how they end up choosing feeding their baby. Skin to skin is good for baby physiology no matter what they choose to feed their baby. It results in greater awareness of hunger cues, not scheduled feedings, as I said, facilitation of the mother-infant bonding, and stabilization of infant physiology without medical intervention. Why should hospitals implement the baby-friendly steps? Well, it's a move towards evidence-based practices, and we always want to try and have evidence-based practices. Breastfeeding duration is impacted by hospital experience. We know that hospitals that have good practices have better breastfeeding duration and exclusivity. Incremental changes lead to cumulative effects. Just implementing one or two, it snowballs. You put one or two changes, and it creates a different environment, and there's more enthusiasm about implementing further steps. Many of the 10 steps are easily adapted as quality improvement projects, and it meets consumer needs. So how, for those of you that are physicians, how can you be, how can you become a baby-friendly physician? You can implement the 10 steps in your own practices, and as for anybody who's interested, I'd be happy to share. There's a couple of different documents that are written about the baby-friendly office. Support immediate and uninterrupted skin-to-skin, straight from the perineum onto the mom's stomach or chest. No supplementation without medical indication. Encourage rooming in, having mom and baby in the room 24/7 together. Refer to the ABM protocols for breastfeeding-related issue. I already talked about them in a little bit. And as a result, you as physicians will benefit from all of the staff giving consistent information when you're in a baby-friendly hospital, and you can have confidence that you have evidence-based practices. So the prenatal providers, I'm not sure how many of you are family physicians who take care of women when they are pregnant, but this is an incredibly important and intimate time in a woman's life. And you really develop such a bond with many of these women, and it's a really, or at least the women are bonded to you. And it really is a trust-based relationship with the provider. And as I said, the evidence reveals that if physicians are neutral about breastfeeding, it actually has a negative impact on mothers choosing to breastfeed. So as I said, we no longer, we're all taught in medical school, ask an open-ended question. But from a breastfeeding standpoint, it's been shown that that open-ended question gives the impression that breast milk and formula are the same, which we know is not true. It's sort of saying, you can smoke or not smoke. Well, we know that's not true. You really shouldn't smoke. So the same way we say you should not smoke, the thinking is we should say you should breastfeed your baby. You want to educate the parents and your patients that there is evidence of a significant health benefits for both mom and baby. Both ACOG and AFP, and I'm sure the AAP and I'm sure AAFP recommend 6 months of exclusive breastfeeding, given the clear evidence of benefits to mom and baby. And you do have the Illinois Physician Statement on Breastfeeding that also stresses that. You want to encourage prenatal breastfeeding classes. There's obviously there's no substitute for when mom has a baby in her arms, but a good prenatal breastfeeding class will give background information. It will also help to reinforce and teach the importance of breastfeeding and the health effects of not breastfeeding. As I said, encourage skin-to-skin and breastfeeding as possible as soon after delivery, and encourage rooming in, which helps to assist in creating a good breastfeeding relationship. Just a couple of things that you can think about from a prenatal perspective, saying things like, do you know that there are clear long-term health benefits for mom and baby? Do you know that formula increases your baby's chances of getting certain diseases? And say, I recommend 6 months of exclusive breastfeeding, and make a good positive statement about it. Prenatal breastfeeding classes are a great way to learn about breastfeeding. I highly encourage you to attend a prenatal breastfeeding class. The class will provide you with important information that will help you get started with breastfeeding. And consider having a pamphlet of the local classes available to give to your patients. One thing I tell providers is you don't have to be the lactation consultant. You don't have to have all of the information about breastfeeding. We all have things that we're interested in medicine. But from a breastfeeding perspective, we're asking, have the information available. You all have your preferred, cardiologist that you refer to, endocrinologist that you refer to. Have a good lactation consultant or a good breastfeeding class that you refer to, and you can have confidence that your patients are going to be treated well and get good education. In labor and delivery, for those of you that are delivering babies, say after delivery, we put all babies skin to skin as soon as we can. It's important to help them adapt and stabilize their breathing and blood sugar, and the best way to keep them warm and bond with mom. If your baby goes to the NICU, it's important to start pumping breast milk for your baby within 4 hours of delivery. On the postpartum side, saying things like, we encourage you to keep the baby in the room, avoid formula, and breastfeed on demand whenever the baby seems hungry, because these steps help to increase your milk supply. The skin-to-skin also helps to increase the milk supply. Asking the parents, asking the mom, have you asked your nurse for help with breastfeeding? Many moms, especially first-term moms, think that because breastfeeding is natural, it should come naturally. And that's not always the case. Some moms really do need quite a bit of help, and some babies really do need quite a bit of help. So encouraging your patients to ask for help is critical. And then saying, would you like to speak with a lactation consultant? Mothers and babies, baby-friendly means keeping mothers and babies together. Mothers and babies stay healthier when they're kept together. Interrupting, delaying, or limiting the time mother and infant spend together may have harmful effects physically within their mother-baby relationship and impacting breastfeeding success. From a physiologic standpoint, skin-to-skin care for the mothers increases oxytocin levels, which is obviously good for breast milk, for letdown. It increases endorphins that feel good, those feel-good hormones. It increases their breast temperature so the baby stays warm close to the breast. It increases prolactin level, which increases your milk supply. It has been shown to increase parenting confidence, and it activates the immune response. From the baby standpoint, when they're skin to skin, they stay warmer. It lowers their stress hormone. Cortisol actually does rise a little bit post-delivery. It's a stress reaction for the babies from the delivery, and babies that are skin to skin, it's found to be a little lower. It allows them to adapt and stabilize. It stabilizes their blood sugar, respiration. It decreases their distress. It reduces their pain response to intervention, and it promotes infant imprinting. Rooming in allows for breastfeeding on demand. If the mom isn't with the baby, she can't see when he's having some of those early signs of hunger. Moms become attuned and aware about hunger cues, as I said, supports bonding. It eliminates the distress for both mother and baby. There is this dogma out there that moms rest better when the baby is out of the room, and that has been shown to not be the case. That actually moms don't get better sleep and don't get more rest when the baby is out of the room. They feel better when the baby is with them. It builds self-confidence and parenting confidence. Having the baby in the room with the parents, sometimes there are some hospitals that do everything in the room. They bathe the baby in the room, obviously do the exams in the room. All of the assessments and evaluations are done in the room. That really helps the parents. And it really gives them some confidence. It's not like, oh, you can't take care of the baby, so we're going to take the baby away and take care of it in another room, and then you come back. And then obviously it improves breastfeeding success. At discharge, you always, again, want to see if the mom is feeling confident with breastfeeding, if she would like to speak with a lactation consultant after you leave. After they leave, you can say, call this person or that person. You can consider a handout or a list of lactations resources. If your practice has an information booklet, many practices have sort of, a little booklet they give to new parents with all of the doctors' names and their interests and contact information and some other information about the practice. Add your lactation consultant to that. So, and make them see that it's part of your clinic, it's part of your continuum of care. So what are the next steps? The first is identify your baby-friendly champions, and maybe it's you. You don't, as I said, you don't have to be a lactation consultant to be a baby-friendly champion. You have to be, enthusiastic about the process, supportive about the process, and really able to answer questions and help pilot your hospital through this exciting change. You assess your current practices. I would bet, and I've done a lot of talks specifically for a lot of hospitals, and most hospitals have many of the baby-friendly steps already in place that may need only a little bit of tweaking here and there. And then there are others that have significant challenges on some of the steps. So you assess your current practices, you commit to making the changes, convene all of your stakeholders, develop a timeline, and once you have a plan, you can contact ICAP for possible support. These are your contacts. Mary Elsner is the Director of Obesity Prevention. Beth Seidel, who was on the phone earlier, is your consultant. And Sarah New is your manager for obesity prevention. These, again, it's a little clearer, are all about hospitals, all the counties and the hospitals participating in the We Choose Health initiative. So if your hospital is on this list, please let us know how we can help you. And you have additional resources at ICAP on the ICAP website. All right. Any questions? I guess we'll open it up for questions.
Dr. Ravide, this is Beth. I do have a question. Just as a physician who's very involved in the initiative at UIC, what would be your best advice? I know that you just talked a little bit about some of the things that the physicians can do to help the hospital, but if they wanted to go back to their hospital tomorrow with some ideas about how they could, really kind of lead the way and join this momentum as it moves forward, what would your ideas be for some of the physicians? Because the hospitals have a multidisciplinary committee. I don't know if you think it's best for them to get involved in that or to maybe start a quality improvement project. Where would they start if they want to show up and say, hey, I want to be a champion for you?
Yeah, the first thing I would do is find out who is the chair of the multidisciplinary committee. And reach out to the chair of the multidisciplinary committee and who to ask who's the chair. If there's a lactation consultant in your hospital, if not the director of maternity care services, should probably know, and reach out to them and see what are the needs, and where your time is best utilized. If you have something in particular that let's say there's something in particular you want to address, like the inappropriate use of formula, formula supplementation. You feel that the physicians just don't follow, evidence-based practices when supplementing infants. Well, let them know I want to tackle this step. This is where I want to focus my attention first. It all depends on whether you have a very specific interest or if you just generally want to help move the initiative forward.
On that same vein, if we have some physicians who are not practicing in the hospital, what can a physician in the community do? I think that there are some opportunities maybe for collaboration, and you mentioned a document talking about baby-friendly practices. Can you talk a little bit more about that?
Yeah, so physicians in the community are really important because the time that parents spend in the hospital is minimal compared to how much time they spend with their community physician. So if it's a prenatal provider who's going to be taking care of them prenatally, then really talking about the importance of breastfeeding and getting them as much prenatal education, a breastfeeding class, getting them connected with having them aware of where the lactation resources are should they need them before they get into the hospital. Those are some things that they could do. And then postnatally, obviously, if you meet the parents before they have their child, talk about the importance of breastfeeding and things that they can do, and then supporting them through the breastfeeding process, especially in those first 1 to 2 weeks where we know breastfeeding is the most challenging. There are a couple of documents about how to have a breastfeeding friendly physician's office. I think that I'm reasonably certain the AAP has a statement on the breastfeeding friendly physician's office, and I would have to go back. I would be surprised if ABM did not. I would bet ABM does. So those would be the first two places I would check, ABM and AAP.
Great, thanks. We actually have a question from Laura Hill. Laura, I'm going to go ahead and unmute you so you can go ahead and ask your question.
Thank you. I'm at Alt Memorial Hospital, and we're kind of about halfway through our baby-friendly initiative. And I'd love some hints and strategies for convincing the community physicians who are quite pleased with non-rooming in and quite pleased with formula supplementation.
So these are community physicians who are rounding in your hospital?
Yes.
Okay. The first is in terms of, rooming in versus non-rooming in, rooming in is sort of a hospital policy. So to some degree, you can say, well, that's just what we do now. Babies are in the room. We don't have a nursery. We at UIC, this was before I got there, they just got rid of their nursery. There's just no nursery. There is a place where babies can go if their mom is having, a tubal ligation, or they're, have to be separate for some reason, for a maternal reason, obviously not an infant reason, but essentially there's no nursery. You can mostly, I would say, addressing the reasons for, in terms of the rooming in, specifically addressing what the concerns are. If it's a convenience, many physicians think it's a lot easier if babies are just rounded up for me in the nursery and I can just go boom, boom, boom from baby to baby to baby. But what they don't see, and once you start examining babies in the room, what you don't see is how much faster and easier it actually is, because you're talking to the parents while you're examining the baby, you're answering their questions. I have to admit, when a parent asked me, if I was examining a baby in another room, back when I was doing it, and the mom asked me, what about that spot they have on their knee? Like, I didn't see a spot on their knee. So then you have to sort of hem and haw or go back and think, and the parents are able to ask questions directly right there. And so I think encouraging physicians to try it and see that it actually does make your practice a little bit easier. It's a little unsettling. I think a lot of people find it a little, I don't know why physicians find it unsettling to examine a baby in the room when we examine babies in front of parents every day in the office. But showing them that it's actually easier practice to just do it in the room. From the formula supplementation, the inappropriate formula supplementation, again, you want to address specifically what they are, and then come up with some policies. Come up with some policies that say, or some guidelines, better than policies. Policies sometimes can be a little stringent. Some guidelines for, when are we going to supplement a jaundice baby? Well, what does the AP say? You supplement a jaundice baby when they show signs of dehydration. What are the signs of dehydration? Okay, urine output is this, or lack of urine output. Bowel movements here, weight loss there, and come up with some clear guidelines that everyone can buy into and use the evidence. How does that sound?
That sounds good. Thank you. I like the idea of changing the policy, so they really have to give a reason why they're not following that.
Right. Exactly. I think a lot of physicians are very, very, and I really don't understand why physicians are hesitant to examine babies in their room. But at some point, there are some things that unfortunately you just have to say, we don't do it anymore. And a lot of it, too, is getting the buy-in of the nurses, because who's bringing the babies to the nursery? The nurses. And getting their backup. Nurses are sometimes worried that they're going to get in trouble. The physician is going to yell at me. I'm going to get in trouble because I didn't, do what I was supposed to do. If they have the backup of their nurse manager, and their nurse manager comes out and says, our nurses don't bring babies to the nursery anymore. You go and examine the baby in the room, or you can bring them yourself. Then there'll be a change in practice. I'm not typically heavy-handed. I don't like to say, like, you must do this and this and this. But sometimes, you have to just say, we don't do that here anymore. We don't give pacifiers anymore. That's it. We just don't. We don't give out formula bags anymore. Done.
Love it. Thanks.
Any additional questions? Beth or Crystal, do you have anything else you'd like to add?
I think that this is a force. and a tidal wave that isn't going to be stopped. And so hopefully physicians will, learn to be comfortable riding this wave rather than trying to prevent it, because it really is the best way to take care of mothers and babies, and your patients will be happier, your patients will be healthier, and our practices will be better.
I just have a brief statement too. This is Beth again. To all the physicians who are on this webinar, I just want to really thank you for attending this. Our hospitals really want your support. It helps us so much, and I speak as a lactation consultant at a baby-friendly hospital. It helps us so much when we have a physician on our team. Because you can really make a difference in making practice changes. So many people want to follow the lead of the physician, so you guys are really, really important to us. And your hospitals are waiting for you. They're looking for you to partner with them. So thank you so much for attending. And if there's anything that we can do for you to give you more information, to help connect you with resources in your community as well, we would love to do that. But if that's it, we'll go ahead and end things for this evening. And again, thank you so much, Dr. Revive, for presenting, and everyone who attended.
All right. Good night. Thanks, everybody.